in millimeters. Females should be between 30 and 32 at a minimum. Males should be at 35 to 37 minimum. And most of the time, if they're normal, they have significantly more than this. You clearly have to work closely with a competent dentist, and one of the ways to judge competence is whether or not they put the splints on the mandible rather than on the maxillary bone. Using a proper splint requires dealing with a fulcrum, in that you're trying to bring the lower jaw slightly forward, and if you put the splint on the upper maxillary bone, you have a fulcrum that moves on the mandible, and you can't, that's correct, that you can't move that mandible forward if the fulcrum is on the mandible. If you use a lower splint, the fulcrum is on the maxillary bone, which is part of the skull and is stable, and you can in fact accomplish the movement. The upper one is just simply a mouth guard or a tooth guard. And if the dentist has an ML830 laser, his or her splint work will go much faster as the muscles relax faster. And again, the temporalis tendinitis I mentioned, and sometimes you have to do this injection to treat it. The last section of our webinar today is dealing with migraines, which I'm sure is a very important item that many of you are concerned with. You have to remember that many patients are labeled migraine, don't have it. They either have only a myofascial headache, and the individuals labeling such a patient haven't checked for trigger points, or they have both. If they have both, you can, by inactivating the trigger points that are present, you can reduce the frequency and severity of the patient's migraines and make it much easier to treat them. One thing to remember now as we go through this concept of how to use the laser to treat migraines, aside from the individual who's mislabeled and has a purely myofascial headache, you ought to know that serendipitously it was discovered by plastic surgeons that were doing Botox injections into the glabellar area above the nose, that their patients came back several months later when they were expecting to have another Botox injection, and they mentioned to the plastic surgeons that their migraines had gone away. And this has been looked at by a number of people between that time and now, and most recently the FDA has approved the use of Botox for treatment of migraines. So clearly there is this effect of Botox on migraines, and it's been well documented. Now we know the current theory of causation is based on blood vessels in the pia mater that dilate and constrict at different times, and they will give you these symptoms of an aura perhaps, and or the so-called blinding headache that people have when they have a severe migraine. One of the things to remember is that when blood vessels dilate and constrict, this action does not involve acetylcholine as a neurotransmitter from the nerve to a muscle. Since this is smooth muscle and it is in blood vessels, acetylcholine is not present. We know that Botox only works where acetylcholine is the neurotransmitter at the synapse. That's been known for many years since Botox was first used. Therefore, there must be some other activity involving acetylcholine as a transmitter that is involved in the causation of the migraine. Hopefully, the neurologists and the family practitioners will begin to understand this at some point. As of now, this is not very widespread in terms of their understanding. The next thing we need to know is that acetylcholine is the neurotransmitter at sympathetic ganglia. So that's a place we'll start to look. One thing you need to know in addition now is that the sphenopalatine ganglion, which is a sympathetic nervous system ganglion, which is located atop the ethmoid plate at the end of the nasal cavity, which is about 3/4 of an inch below the glabellar region. And therefore, a Botox injection at this area could easily diffuse to this ganglion and block transmission from the initial sympathetic nerve to a later sympathetic nerve. So clearly, there must be some functionality of this sphenopalatine ganglion in dealing with migraines. That has to be recognized at some point. Several years ago, in 2009, I attended a seminar given by Dr. Barry Glassman, who is a dentist, who demonstrated in a seminar that injection of local anesthetic at the sphenopalatine ganglion not only treated migraines and other types of facial pain, but chronic daily headache, etc. He also demonstrated a number of other techniques for dealing with headaches, but the one that we're interested in is the sphenopalatine ganglion injection. And I asked him what would happen if one used a laser on that area, and he said he didn't know because he hadn't done it, but was interested in finding out and asked me to let him know when I had finally documented the changes. Using the ML830 acupuncture cone attachment, which changes the ML830 3-beam low-power laser to a single beam, where we can use it in smaller areas on acupuncture points and on trigger points, and on this particular treatment, we direct a single beam at the sphenopalatine ganglion, and that usually needs to be done bilaterally, although one side often dominates. You place the laser just above the zygomatic arch, aiming slightly anteriorly towards the maxillary bone at an angle aiming just below the eye socket. I would suggest that you at least try this on patients very gingerly, and make sure that you're aiming below the eye socket. Although the bone does protect the eye, there are numerous blood vessels and nerves that go through that area, and if you have the wrong angles, there might be some problems. I don't think you can cause a significant problem as long as you stay away from the eye, but I would be careful doing this until you feel confident that you're getting it in the right way. 4 or 5 cycles of the ML830 will usually be sufficient to either decrease or eliminate the headache on that side. And it's important to eliminate all the trigger points first before you do this, because you may be dealing with a headache which is not a migraine. Once you've documented that all the trigger points that we've talked about earlier are in fact inactivated if they were present, then we're dealing with a migraine, and you can use this approach to the sphenopalatine ganglion, and you will usually resolve the migraine pain with this treatment. I've also used it on one patient with trigeminal neuralgia with good response, and one patient with a post-root canal surgery who had severe pain both between the first and second stages of the root canal, as well as after the procedure. And I've also used it on a few patients with very atypical types of facial pains, where the whole face will start to relax after this treatment. Initially, the laser treatment may only last 1 to several hours. Each treatment results in longer and longer relief as long as the patient works on keeping their trigger points relatively inactive. Again, we're going to look at some of these trigger points that will set off the migraines, and one of them that